Well, good morning everyone and welcome to our rheumatology webinar. This is our second webinar. The first one was on cardiology and we're delighted to welcome you all this morning. My name is Richard Wyatt-Haines and I'm joined by Dr. Kirsten Mackay and Rian Penford, a specialist nurse in rheumatology. Now, whilst this morning's webinar is labelled about being about the rheumatology app, in truth, we're going to go much wider than that. It's really about how an increasingly busy rheumatology department copes with reducing demand in a variety of different ways. And yes, we'll focus on the app, but we're also going to look at some examples of other approaches that Kirsten and Rian and ourselves have been working on to make that work more effectively and really address some of those pressures. In terms of input this morning, we're going to have I'm going to do a couple of minutes here and then we'll have around 20-25 minutes with Kirsten, followed from there with a question and answer session that will take us through the whole issue that we're going to look at this morning in terms of the app, and will be your chance to pose questions of both Kirsten and Rian. In that regard, please can I encourage you to put your questions up online as we go along. My plan is to pick them off at the end of the input session. So that would be broadly the idea. Obviously, if something really stands out where somebody's confused or not sure, we'll stop and try and answer it then and there. So we can see the questions here as they pop up, so please do so. But we thought we'd start this morning, rather than us talking as clinicians or us from Health and Care videos, we thought it would be ideal really just to start with a patient view of what we've been doing, because actually it's the patient that we're really interested in. What is their experience of care? How do they engage with us? But equally, how do they engage with us so we can manage the pressures, the growing pressures of demand? So we're going to hear from one of Kirsten's patients called Lily, and really to my mind she says it all. What she shows us in this short 1-minute clip is that there is an opportunity to transform care packages using technology, that there is a desire out there amongst patients for us to do this for them, and patients engage with this and with technology. So let's hear from Lily if we may. Here she comes.
The problems for me would be I'm going away, can I have immunisations? Can we have the flu injection? I'm not very well, I've got a real flare-up, can I have some help please? And so you'd be ringing the helpline all the time or sending an email because you didn't have that information right in front of you. You can't always retain information, but if you've got it on a screen that you can get at quickly, it's so helpful. We have booklets, and there's information leaflets, and you're told by the consultant or the nurses, whichever you see when you have an appointment, but it's retaining that and it's finding the books, whereas everybody carries their phone around or it's in the house with them, and it's so easy then to just go to the app and you've got the information right in front of you. I've introduced several people to it who've now got it on their phones and are able to use it. So it's really good. I mean, I think it's an excellent way of communication with the rheumatology department. If you look at the app, you can get all the information you need. You don't need anything else.
Lily, that is absolutely wonderful, and thank you. I think interesting insights from me from there is her comment. Everyone has a phone with them all the time, and how she shares it with her friends. A great story. And I think what Lily does is set up our discussion for this morning and the challenges that Kirsten and Rian have been looking at. So what I want to do from here, if I may, is hand over to them to start talking about the ways in which they've been handling this pressure that exists around them and the approaches that they have adopted. So here we go. Over to Kirsten and Rian, if I may.
Hello, this is Kirsten here. I thought it would be worth just starting about who we are, and we're an outpatient-based specialty. We're rheumatologists. We're in a small to moderate DGH in the southwest of England. We deal with chronic diseases. They all have a significant morbidity and mortality. There's an increasing follow-up workload. Now, UK figures tell us that in rheumatology circumstances, the number of people we look after and follow up doubles every 5 years. Now, clearly, we don't have a doubling in staff in a 5-year period. So it's quite important we try to find new ways of managing this. We deal with a lot of intensive medications, disease-modifying therapies, biologic therapies, and these require regular monitoring and careful follow-up. We can't discharge people on these drugs. As a result, we have an increasing pending list, and we have not been managing to keep up with that. We have delays in seeing new patients. Our routine waits went out for a very long period of time. With people with early arthritis, we're trying to see people within the 3-week period, which has had a knock-on effect with all of our appointments. It's also important to start people on these medications quickly. None of them work very quickly, so you do not want to delay the starting point. And national standards say we should be starting people on drugs within 3 weeks. So we had a number of problems that we needed to address. Now, the way I look at things, it all stems from the 100% increase in workload every 5 years. Now, there are many ways of looking at this. And today I'm going to concentrate on the patient education and support, so we can help people self-manage and improve self-efficacy, and that seems to be a really important area to consider. And after that, we're going to talk about shared medical appointments and how you can get people onto medications quickly, how you can educate them well as a group. So let's start with the problem. So I've talked a little bit about this, but in our area we have very scattered healthcare. There are 5 peripheral clinical sites that we work in. As I mentioned earlier, we've got an increasing number of patients, but we haven't got an increasing number of staff. We needed a better, efficient service. We needed good access. We also wanted it to be patient-led, and we wanted patients to be pleased and happy with the approaches we were taking. We need to give information to everybody who attends our service, and I think Lily gives a very good example of how on earth can you manage to retain the information that you're being told in clinic when you've just been given the diagnosis of rheumatoid arthritis, which is a pretty fundamental problem, and you're feeling rubbish at the time. And then we give out booklets, but I don't know about you, I certainly lose everything like that. So we wanted a way of keeping everything together. I also looked up online and asked the question, how do you treat rheumatoid arthritis? And I had 35.5 million hits online in Google. Well, how on earth do you weed through that and work out what's true, what I can trust? There's also a huge number of different drugs available to treat, so there's a lot of information about all of those. And again, it goes back to that idea of what is the information that I need and how do I access it readily. So it seems to me you need something that you can get hold of quickly, and this is why we developed the Rheumatology Connect app. So we started developing this in January 2018, and I work for Torbay hospitals, and they are in partnership with Health and Care Videos. And I was in a very fortunate position when I approached Health and Care Videos in December 17. I was pushing an open door because our hospital had just said, yes, we'll do some apps. And I went and said, I think we need a rheumatology app. And they said, oh, good, excellent, let's do it. So we started in January 18, and by June we'd launched it. So that's pretty impressive in NHS terms, isn't it? And I had fabulous help from Health and Care Videos, and we just got on with it. Rian and I, and a number of others from the rheumatology team, wrote all the content. And the app was funded by one of our local charities called Torbay Arthritis Project. So thank you, TAP, that was really helpful. And we focused in the first instance on giving patients the information they required, what Lily is talking about. We also focused on making sure they could get hold of us easily. I'm sure you will have all met patients who've complained to you in clinic where they have said, I rang the rheumatologist secretaries and I waited in a queue for ages and I left 6 messages and nobody rang me back, etc. Well, now our patients through the app can ring the rheumatology physiotherapist directly, or they can send us an email directly. They don't have to keep going through one port of call. And we were very pleased last week to receive a highly commended in the BMA award, the Patient Information Award last week. And so it was nice to they acknowledged the app, but I hope next year when we have improved it, things will be better. So a few facts and figures. Since we launched in June 18, we've had just shy of 1,500 downloads, and we've had a steady stream of downloads. We run an education afternoon, which Rian's going to talk about later, once a month. And with the eye of faith, if you look at the bottom left-hand graph, you will see there's peaks at the beginning of most months. You will also see there's a very large peak in May, and that's because I gave a talk at the British Society of Rheumatology meeting, and I got everybody to download the app in the meeting. On average, people spend about 4 minutes every time in the app, and that would give them time to look at a video. We have plenty of videos attached to the apps on lots of different subjects. They're all less than 3 minutes because I think short and sharp is quite important rather than boring people. And we have information about how do you deal with methotrexate, what is rheumatoid arthritis, living well on biologics, a whole range of different things. A lot of people spend time on our contacts page and also our clinic page. So for instance, if I'm doing a clinic, for instance, in Newton Abbot, and then patient's next appointment in Paynton, they may not know how to get there. So we've done a whole page on where the clinics are, how to get there, what the parking costs are, how do you get there by public transport, and more importantly, what's the postcode. So hopefully people won't get lost and miss their appointments as a result. So here is an area of the southwest. As you can see, we are in the Bay, Torbay, and you'll see where it says Newton Abbot and Paynton. And we've had about 413 people download in that area. Exeter is our next nearest hospital, as is Plymouth on the other side, and people are downloading it in those areas. There are downloads actually all over the world. People have found it on the internet. And here is some feedback that we've had. We've put 3 slides with feedback because we think there are relevant points. This first feedback is from a lady who's had long-standing rheumatoid arthritis and knows all about it. But she spontaneously said this very relevant thing, which is one of the main issues with health information now is the use of the internet by patients. There's a plethora of websites with information and advice on any condition you could name, but not all are proven. And I think patients become very confused with it and are possibly misinformed. And that's so relevant and one of the main drivers for developing the app. We wanted to produce trusted information for everybody who attended our department. We didn't want to make it condition specific, it needed to be there for everybody. There are many other comments that we have had. Somebody else who's had rheumatoid arthritis for a long time says it's still useful to be up to date with treatments and advice because they change and improve with time. And other people say the app is simple to use, the videos are informative and concise, and the contact details are very useful. So they can contact our specialist nurses when they need to. And a lot of people like the signposting to other websites for information. So what next? Well, we've raised some money and we are now developing the app to make it interactive. One of the aims that I'm keen to do is to not just inform people about their condition, but also allow them to help manage it. So it seems to me there are a number of features that we need in this new app. One is a calendar function to remind people about their appointments. By the time you have a chronic disease, and you may have more than one at the same time, there are so many different appointments with various healthcare organisations, it's very easy to forget. And I've had a number of people missing appointments with me because they've got confused with their x-ray appointment, for instance. So if we have a function to remind them of where they're supposed to be at what time, particularly in a fairly wide geographical area, I think that's quite important. A medication section I think is important. The drugs that I use, the biologic therapies, they're often not on the GP records. And if somebody ends up in hospital very unwell, the people looking after that person may not realise they are on anti-TNF therapy, for instance, and that would have a great impact on how they treat their underlying condition. For instance, if they have pneumonia, it might alter what type of antibiotic they give them. They might give them intravenous versus oral, if they knew they were on an anti-TNF therapy. I think another area, remind us what to discuss in clinic. I'm sure you've all come across this, where somebody says to you, I knew there was something I meant to ask you, but I've forgotten what it is, and I'm going to remember as soon as I get home. So if we can find a way of just helping them have the best outcome from their clinic appointment. And finally, I'm rather hoping if we can provide people with outcome measures they can do themselves, that they will continue to persevere with their treatments. a lot of the medications that I use take 4 or 5 months to fully work, and that must be a bit boring and a bit tedious to carry on taking a drug that doesn't seem to be making much difference. But if you could perhaps do your joint count once a week or once a month as you're taking these medications and you saw that changing, I think that would help you, encourage you to comply with your treatment. In the longer term, it might also mean to say that if you're very well, you could send me that outcome measure and say, look, I'm really well, this is my joint count, or this is my BAS-DI. I don't need to come and see you, I'm really well, I'd like to go on holiday really. Would you mind if we delayed the appointment 6 months? And I'd say, yeah, that's fine. On the other hand, somebody might ring up Rian and say, look, I'm in real trouble, I'm having a flare, this is my joint count. And Rian would be able to say, ooh, yeah, that's pretty bad. We'll see you today, or we'll see you tomorrow. And it will help us decide who needs to be seen when and prioritise. So these are the areas we're looking at. We clearly need to continue looking at reduction in appointments. We see people to teach them how to inject injectable methotrexate, for instance. Now we reckon if we provide people with a video on the app, particularly if people have injected themselves before with an injection pen, then we probably could avoid people having to trog up to hospital and find parking and all of that by looking at the app. And probably it would be a good idea if there was a way of them looking at the video and signing to say they fully understood what they were doing and did they need any further help. So then we would have evidence in their notes that they had been taught appropriately. So we think there are ways of reducing the numbers of appointments for all sorts of different ways. Big point, I hope it makes it easier for patients to manage their condition and feel more in charge. I mean, that's the big reason why we're doing it. So you can download the current Rheumatology Connect app from the App Store. It's free for any of your patients. And we are in the process, as I've said, of developing the next stage of the app, and we hope that will be ready by early 2020. And I've got one more thing to say before I'm going to hand over to Rian. So shared medical appointments, that's the other area I think I'd like to talk about. Again, huge volume of patients. How do you manage to get people onto drugs quickly? How do you educate people quickly? One-to-ones, if you have an increasing number of people, just stop working because the delay in seeing people in clinic gets longer and longer. And to give you an idea, before we started starting people on medications in groups, we had a 16-week wait before we could get people onto their medication. Now, bearing in mind it takes about 16 weeks for it to work, that was terrible. But we have really good evidence now that it's much quicker. But I'm going to hand over to Rian. We're going to talk about education and starting medications, but we've also been doing some work on shared medical follow-up. We haven't got time to talk about that today. Let me hand over to Rian.
Hello, so I'm going to talk firstly about group education. So just tell you a little bit about that. It involves now the whole of the rheumatology team, the occupational therapists, physiotherapists and podiatrists, the specialist nurse, the consultants. So to give you some history, in the past, until 2017, the diagnosis was made. They referred for some education. This was to be seen by the physio, OT and podiatrist in one session in one afternoon, but the maximum patients they could see were 3 patients at a time. This proved difficult, unfortunately, lots of DNAs for different reasons, so it wasn't a particularly efficient service. There was no further education from the consultants or nurses. So what we did was we built a group education monthly meeting. This was a broader education. It was to improve self-management, and it was to help patients to be more aware of who to call and when they can call. So it was to give them lots more information, but in one place. They could bring anybody with them. They could bring a relative or a friend. There was no capacity. There was no problem with capacity. So we could see 20 patients at a time plus. So depending on who had had a diagnosis that month, and then they could bring somebody with them. So they were seen within a month of diagnosis, and then they had just short presentations from consultant nurses, physio, OT and podiatry. This was once a month, and we've had excellent patient satisfaction. We also provided time for questions and answers within that time. We were supported by Versus Arthritis. We are supported by Versus Arthritis and NRAS, who come along and display their information. Then the patients that come to the afternoons can then sign up to go along to their meetings. They have more support, they are aware of the sort of support around them, and also they have peer-to-peer support. They can chat over a cup of tea or coffee, and patients either find this useful or not, but it's available to them. So we've had excellent patient satisfaction. We've done continued to do audits, but we've maintained patient satisfaction at 4.7 out of 5 for each talk, with the questions and answers. The clinic appointments saved. So in the past we saw 7. We could see 3 patients booked in, but with many DNAs. In a 2-month period in 2016, we saw 7 patients. In 2018, with a new group, we saw 26 patients over 2 months. So the figures are there. We saw a 271% increase in patients' education at the same time. So this proved to be an excellent, in that we could see so many more people in one time, and also that we maintained patient satisfaction and it was consistent across the audits.
Okay, I thought it would be worth just briefly talking about how you can fit group clinics in and how they integrate with each other. So if I took the example of somebody with a new diagnosis of arthritis, I'd see them in my early arthritis clinic. We'd go through the diagnosis, explanation, written information. I'd talk about treatment, I'd give them information about that, and I'd organise the initial investigations they needed to make sure they were safe before they started drugs such as methotrexate. And I would start their simple treatment at that point. But that was only a 30-minute appointment, and I did ultrasound in that appointment. So there's an awful lot of information to download to a patient, and I think they get completely stunned, if I'm honest. I follow it up with a written letter, but even then, it's not enough. So I then offer them the opportunity to attend our MDT group education afternoon, and that should be within about a 4-week period of their diagnosis. As Rian was saying, there are 5 talks with a range of different areas with plenty of time for questions and answers. So on the whole, that's a good top-up in terms of what they need to know. We then ask them to come to our group disease-modifying therapy clinic, or shared medical appointment, and Rian's going to talk about that in a second. And if I'm going to put them on dual therapy, they end up having 2 visits about a month apart. We tend to start with methotrexate, we get them established on that, and then we ask them to come back to start on sulfasalazine. All the information and investigation results have been through before they start that, and we'll talk about that in greater detail. We do have a facility to do one-to-one, because group clinics are not for everybody. And particularly if you're deaf or something like that, it's very difficult to be in a group. But provided you're okay in a group, the next thing, and certainly in my practice, I will then see people for follow-up in a group follow-up clinic. And I run that on an evening at about 5:15 in one of the local hospitals where we have a large room, and I have a range of different people in there. Now, we haven't really got time to talk about that today, but really the whole point is, by the time you have been to a number of groups, that's the way it all works, and you've got to know the other people who have the same disease as yourself. And actually you see a friendly face when you come to clinic, and we do a lot of education in our group follow-up. Rian and I run that between us, and that's a very good way of keeping an eye on people with early disease, but also mixing them up with people whose disease is under good control, so that they see the light at the end of the tunnel and realise, hopefully, it's not a train coming towards them, it's actually the light, and they're going to get better. So we run a range of other clinics, but what we thought we'd talk about is getting people onto medication in a group, because that is a really easy way of trying to get people onto treatment quickly and safely. And I'm going to hand over to Rian to talk about that.
So, as Kirsten's already said, the decision to start the medication is already made with written information in clinic. Investigations are all organised. Then the way that we do this now, the focus really is that it is the safety and also that the right member of team is doing the right job. So then the next part of the procedure is that the admin staff, then they book the appointment. These are held weekly for each different medication, and the admin staff chase the results. The nursing staff, prior to the appointment, check the blood tests and check the x-ray, organise the prescription. The consultant then checks the prescription and signs the prescription. So then we're all ready to go ahead with the medication when that patient attends the group. So we have 3 groups on a Wednesday afternoon. We can see 5 to 6 patients per clinic. We can see more if we need to, but that's our sort of average amount, 5 to 6 patients. We then give them some education about the particular drug that they're taking. So it's the group that they're in is specific to that drug. There's lots of time for questions and answers, and people, very often people will bring questions with them. We also have a room that's big enough that they can bring relatives with them. So that's really useful, again, as we've said before, just to retain information and to remember that question, that burning question that they may forget to ask. We then provide them at that appointment with 6 weeks of medication. So they should leave at that point, at that appointment, with their prescription in their hand, and then they go down to the pharmacy and get the medication at that time. They should be aware of when to take it, how to take it. They also sign at that point a checklist to say that they've understood the information. They'll have their blood tests and off they go. Then the aftercare is then done by admin again. So admin staff then send a shared care agreement letter to the GPs. There's a letter also goes to the patient just to reiterate all the information they've had before and to remind them again about how to take the medication and when to take it. Tells them about building up the medication. It again tells them about blood monitoring and how often they need to go to have their blood tests. It also again gives our contact numbers, reminds them about the app, reminds them of the helpline number and the email address. So it should arm the patient again with everything they need in order to comply to the medication and ultimately to be well again. We then see them in a group follow-up. So this means that we can see patients with early disease. We can see them more often, and it also means they have a 2-monthly review. They see the consultant and the nurse, and this has proved really, as Kirsten's already said, really useful for people with early disease and also people that have had disease for some time. But it's a really useful group. Okay, so we've also done some patient satisfaction questionnaires. There's a 69% reduction in follow-up appointments. Patients continue to be satisfied, so it remains at about 4.7, consistent with multiple questionnaires across the board. The other thing I wanted to mention was telephone appointments. So we also, just before we go on to this slide, we also can arrange telephone appointments. So we offer a combination of methods to be seen. So either in a group clinic or one-to-one or a telephone. Lots of patients that have already started one medication, all they need is to go through a checklist and to agree, to find out the differences between the medications. So we offer telephone appointments for this, which are really useful. Some people live a great distance from the hospital, or they can't drive, or they need public transport, or some are housebound. So to do a telephone appointment for the medication is really useful as well. Pass over to Kirsten.
Okay, this is a slightly complicated slide. It was trying to bring lots of information into one table, and I'm not entirely sure I brought it off. But in essence, this was an audit looking at 607 people starting on a disease-modifying therapy, and of that, 59% came to our group Demark clinic. 27% were via the phone, so you can see the majority of it happened outside of a classic one-to-one nurse-led 45-minute appointment of getting somebody on a medication. So we've been running this service since about 2006-07, and the reason we set this up in the first instance was it was taking a very long time. If you were giving each patient one-to-one 45 minutes, there was an increasing backlog of people needing to start their medication. We were just not keeping up with it. And we felt that was unacceptable, which is why we started seeing people in group and ringing them up. So if you look at the fourth column along where I've said equivalent time, minutes per patient educated, I was just trying to give us an idea of this saving in time. So the classic way for us certainly was one-to-one, nurse-led, 45 minutes to go through everything in great detail. That's great, but we just didn't have the capacity. Over the phone, probably about 15 minutes per person. But if you did it in group, we were cutting the time in half again. On average, about 7.5 minutes by the time you were seeing 6 people at a time. We are a bit limited by the size of our room, so 6 people tends to be our maximum, although I am told if we tried to make it bigger, it might be a bit complicated. It probably might not work so easily. Rian's nodding at me here.
Questions is probably difficult.
Yeah,
questions and answers.
more questions. If you look at the final column, I was just trying to give us a flavour of the percentage of clinic appointment time we have saved by using a combination of mainly phone and group clinic. Group clinic being the bigger proportion. And I reckon it's about 69% reduction in the time saved that we would have been taking if we were still doing the old one-to-one system. The other thing I think it's probably worth mentioning is I have said to you that it was taking a long time to get people onto drug one-to-one. Well, we did an audit about 2 years into doing this, and we got it down to 10 days. Now, bearing in mind the national figures say you need to get people onto drug within 3 weeks, 10 days seem to be pretty good. And we go through periods of time, if we don't have enough admin staff, where there's sometimes a delay. But usually we can keep it down to 10 days, 3 weeks, maximum 15 days. And we're aiming at less than 10 days if we possibly can. Now, I think that is the end of what Rian and I are going to talk to, and I need to hand over to Richard.
Hello again. Thank you, Kirsten, Rian. Thank you very much. Hopefully that really gives you a very clear insight into some of the work that's been going on and triggers some thoughts and ideas on how you can develop your own services. I think the message that stands out to me from that is that you can combine an enhanced patient experience and deliver higher capacity or reduced demand. It stands out through all the work we've been doing, and particularly Rian and Kirsten have been doing, and you can bring technology in there to play, because all this work here with the groups and the telephone support is even more enabled once you've got the app in your hand as well. That's what makes it even easier. And that really sort of closing up on the sort of input side, that's really where Health and Care Videos comes in, is really our work about transforming healthcare using platforms or apps, video quizzes, but digital information to just change stuff. And here's some examples in pathways we've been working on recently. On the left-hand side, podiatry, just simple interventions using platforms, using apps, using videos to try and reduce the amount of time that's involved in their particularly outpatient appointments. And then equally on the right hand side, some examples from our work in cardiology where we've got some significant changes that we've made, delivering even in the first year significant impact. But today is about rheumatology, today is about Rian and Kirsten, and today is also about you, and from here on in really thinking about the questions you may have to ask of our guests this morning. Now I've got a couple of obvious ones at the top here. I think just Kirsten, just give us a flavour of the size of Torbay. The health economy is a question coming in from Alan, and if you could help out there, that'd be wonderful.
Hello Alan, thanks for ringing in. We're about 380,000.
Okay, and in your population of patients you're handling in your clinics?
We're looking after about 2,000, 2,500 people with rheumatoid, about 500 with ankylosing spondylitis, 500 with psoriatic arthritis, and a range of other conditions, 500 or so with connective tissue diseases who are regularly under our care, and a range of other things.
Thank you. And somebody's asked, an anonymous attendee has asked, are you the first trust to offer something like this? What's your sense of that and your awareness around the country, Kirsten?
I think that we are doing a broader range of things than I hear most people doing.
Yeah.
There are other places doing apps, but I haven't come across an app that is aimed at every patient that attends the appointment. So there are apps, for instance, involved for people with ankylosing spondylitis and psoriatic arthritis specifically. There are apps that are specifically involved for people with rheumatoid arthritis. But I haven't seen one that's focused on everybody who attends the department. I haven't really come across many places doing much in the way of shared medical appointments. Up in the north of England, I know that there is an area doing that. And in fact, I took some of the learning from there when I set up my shared follow-up. Have not come across too many places doing shared medical appointments to put people on drug.
Interesting, thank you. And somebody asked a related question relating to that. I'm just trying to track it down, bear with me a minute. It was, there it is. When you mention the reduction in MTX appointments, does that mean methotrexate appointments? Does that mean teaching or administration appointments?
Oh, well, if we're talking about injectable methotrexate, we don't administer ourselves. At the moment, people come for a one-off education session where we would teach them how to do it and inject that day, on that day, one-to-one. If we're talking about tablets of methotrexate, then that's about education.
Thank you.
Yeah.
And is it your experience that people need a lot of sort of triangulation and help on using the app and accessing it and using it?
No, when we see people and introduce the app, we probably show them, it downloads very quickly, but we probably show them a couple of things. I often show them the contact details because that's first what people like to see. Yeah. If I've seen them in a medication clinic, then I would probably then show them the video for the medicine that I've just talked about, so just to so they know it's there. So, but no, a few moments. I like to take a little bit of time just to show them certain pathways, but it's, then off they go. It mostly to do with what they've been to see me about, usually, is how I would do that, yeah.
Thank you. And sticking with Rian, Shandini's asked, do you have any issues with information governance with group clinics?
We've, the checklist that we do beforehand, we've asked the patient anything that, any information that they may not want to share. The patients don't see each other's information. They each sign their own checklist. So for confidentiality point of view, then they're not seeing other people's information. All that we're giving them is information about the drug, not about their condition or about anything in particular to them.
They're also all aware that they are coming to a group.
And
so they don't. We offer the opportunity to come to a group. We don't make them come to a group. So if they choose not to come, we see one-to-one.
Yeah.
Or telephone.
And your message to other clinicians that would be thinking about adopting these sorts of approaches, what were the things that would stand out to the pair of you from experience?
I think it's revolutionised our practice. I think the use of videos is just confirms all the information to the patient. It reminds them everything. They don't have to hold booklets in their hand that they might forget where they've put it, and they don't have to be able to read the information, and that's difficult for some people to read the information, and there's so much information that we give them, and it's just a great support tool for them to manage themselves and feel like they're in control.
I think there are a couple of things as well. Some people retain information better if it's written, and some if it's on video, and we have both on the app.
That's right.
I think the other thing is, in my experience, there hasn't been very much uptake of the apps that are disease specific that are maybe internationally produced, because people don't really know who's made them, and they don't therefore know whether the information, they can trust it. But with what we've done with the app is they know their clinical team has made it, and therefore they know we're only putting stuff up there that we are going to tell them anyhow. And therefore the uptake's been very good because people have trusted it and have realised that it's local. And it's for them. It's not for sort of some random person in the middle of the world somewhere. And I think that's made a big difference. With regards to group clinics, if we didn't have our group medication clinic, we would be absolutely stuck. We would be so behind the curve in terms of getting people on treatment. That's been one of our fundamental necessities. And we've been running that 12 years plus now, and I would just hate not to do it. The newer groups that we've done on the back of our experience with group medication are also working really nicely, and I would encourage anybody to consider it. It's not for every patient. There are people who would disrupt groups, there are people who can't hear, there are people who are just too shy to want to do it. Never make anybody do it, but for a lot of people, in fact there are quite a lot of people who come, and if they ever get sent to an ordinary rheumatology clinic, moan quite a bit because they much prefer the group. So it's horses for courses, and it's probably not for every clinician either.
It's done in a very a very professional but very friendly way.
Yes.
And that's how it is run. People, the people that attend feel safe. They have our undivided attention, albeit with, they are sharing it, but they have our attention for that time. And also that it gives opportunity for somebody else to ask the question. So if I had a question but I just didn't dare ask it, then somebody else sat next to me is bound to ask it. So that's been really useful. And also that relatives, there is a little bit of capacity for more people in the room so that they can bring somebody else to listen. But it's done in a professional way, but it's done in a very friendly way.
Thank you.
And you can get out information quickly to large groups of people, which is very important. I mean, with the advent of biosimilars is a very good example. We were able to let 20 plus people every month know that their medication might be changed because a biosimilar was coming in. Whereas if you didn't have a group, you'd be sending people a rather, sterile letter, I suppose might be the best description. And that's not such a good way of talking to people about a change of a very important medication. You need to be able to discuss it.
I'll pick up on an issue from there. I'm conscious of time and just a couple more minutes, I think, before we close. But I'll just pick up on some operational issues that have come through on the app, or questions on the app. But one of the things we're just lifting up on Kirsten's last point about keeping people informed, one of the things we're now working with is push notifications out of the app. And the really interesting thing about using push notifications just to keep people informed is you're putting knowledge into patients' hands directly. It's in their phone, they see it, it's much more personal, and they respond much more actively than they would through a letter or any other means. So you're making that connection. So that is another vehicle we're using alongside, and that's the advantage of sort of deploying technology in this way. There's been a couple of questions just asking whether this can be adapted for other trusts, and absolutely yes. We've built it so it can be done. The video content can be adapted as need be locally. Most of it should be pretty generic, but equally we can build content in that's specific to individual trusts with contact details, with clinic details, exactly the same. So yes, that can be done, and give us a shout if you want to know more about that. Just trying to see if there's any other major questions here. There are a couple on costs. That varies, and just to respond to it, because that's appropriate in that respect. In terms of costs, it depends on what's needed in different trusts, and we can talk to people individually. So I recognise you've asked the question, but I think it's better if we talk about that individually. A wonderful question just popped up about using different languages on the app. That's feasible, very, very feasible as well. Our videos are all subtitled in English as a standard model, but the most foreign language subtitles we put on the videos is 13 to date for for a hospital up in Birmingham. That can be readily achieved, and I think the combination of English with foreign language subtitles works really well in terms of accessibility and issues around that. And gosh, there's loads more we could answer, but I'm really conscious of people's time now. We are 45 minutes in and it's flown by. What I would say, I'm going to repeat a very kind word from Ben, I think, to Kirsten and Rian about, Ben very kindly says, this is an excellent initiative, by the way. Thank you, Ben. That's really good news. But I think you'll have got a sense from us today of the possibilities that are presented by looking at the pressures that are building, have built, continue to build in rheumatology and other clinics, that you can address these in fundamentally different ways, improve the patient experience, improve your ability to cope with the demand, to manage demand more effectively, and I think, I'm speaking for Rian, but I think I would say and have a better experience for staff as well. I think, would that be
Yeah,
fair to
definitely.
say as
Yeah,
well?
Definitely. Yeah.
Because you feel you're more in control, don't you? That would be
Yes.
my sense in working
Yeah,
with you over the
definitely.
years.
Yeah.
So,
Yes. Yeah.
wonderful. So for us here at Health and Care Videos, I'd like to say a final thank you to Kirsten and Rian for their wonderful insights on the work they've been doing and what they've achieved and the impact they have made by transforming healthcare. We're delighted to work with them. We look forward to developing now and finishing off the second version of the app. We hope this morning has been of value to you. If you've got any questions, we have contact details, he says, hopefully on the final slide. And there you go. Please get in contact with us and we'll guide you through how we can help you out. Thank you everybody very much. Have a great day and have a great weekend. All the best. Thank you.
Thank you.
Thanks.